Thank you all for coming. I wanted to just kick us off a little bit by having a few slides on consideration for COVID-19 and lupus. Okay, so I actually borrowed this photo from a preprint that just came out, and it just shows us how quickly information is moving. But I thought this was really interesting because it talks about, you can see over on the left-hand side vertically, you have severity and clinical manifestations, viral host interactions, pathophysiology, and interventions that we've come up with so far. I think one of the most impressive things is that we've come up with interventions so quickly, including the vaccines. But I put little purple lightning bolts here because everywhere along the line for COVID-19 pathogenesis and host responses, we may have differences for lupus. So, our patients tend to be on immune suppressive medications and have abnormal immune systems. So does that lead to increased viral replication? Our patients have more cellular stress, poor clearance of apoptotic debris. Does that affect our cellular mechanisms? Perhaps there's a blunted innate or adaptive immune response. So there are all kinds of reasons why lupus patients, including comorbidities, might be at higher risk for COVID-19. Okay, and we've had some data come out. So a number of cohorts have looked at COVID-19 outcomes in lupus patients, including one here in New York, Columbia, with a 450 COVID patient database, the Global Rheum Alliance Registry, and a French registry. Looking at COVID-19 patients, and what we've shown so far is that hospitalization for lupus patients who have COVID-19 tends to be high. So I wanted to tell you guys a little bit about the cohort at NYU, the Warkoff cohort, and what we found with regard to risk factors for COVID-19 and outcomes in COVID-19 for lupus patients. So this is a large cohort. So over 400 patients were screened, and we ended up recruiting 226. So this is longitudinal. And we've grouped our patients by patients who were COVID positive, patients with COVID symptoms who were never tested, COVID negative, and patients who did not have COVID and were negative, never tested. And a couple things came out, and this is consistent with other data, but patient level factors that associated with increased risk of COVID were age, of course, BMI, so patients who were heavier were more likely to have a positive COVID test, and number of comorbidities. So patients who had more comorbid disease on top of their lupus were more likely to have get COVID-19. And so what about patients who were hospitalized versus ambulatory? Here we found again that age mattered, but we also found that our patients who were not white were more likely to be admitted to the hospital than patients who were ambulatory, as well as patients who were of Hispanic ethnicity. And that follows with some of the disparities we've seen with COVID-19. And I think it's especially important because we know that lupus patients tend to be Black and brown. We found that patients who had a history of lupus nephritis, those who had APLS, and those again with more comorbidities were more likely to be admitted to the hospital. So in addition to individual level factors, we also wanted to look at neighborhood factors because we know in this pandemic that living in a neighborhood where there are more cases of COVID means more spread. And so we wanted to look at that in New York City with our lupus patients. And so what we did was we piloted this area deprivation index. So this is an index of variables that are geocoded by neighborhood block. And it's able to map out how socioeconomically depressed an area is. So high area deprivation index means more socioeconomic stress. Low area deprivation index means low socioeconomic stress. And you can see this is a map of New York City, and the area deprivation index deciles is mapped out. So you can see up in the Bronx, some parts of Brooklyn, we have more disadvantaged neighborhoods, whereas Midtown Manhattan and Lower Manhattan tend to be least disadvantaged. And so here you can see, so these are the deciles of area deprivation for our patient cohort. And we found that our patients actually represented all across the spectrum. So this is a frequency plot, pretty normally distributed area deprivation index. What we found was very interesting. So we found that regardless of the patient's personal race, living in an area with a higher population of white people associated with less likelihood of having a positive COVID-19 test. As well, living in a neighborhood with fewer high school graduates associated with more likelihood of developing COVID-19. People who lived in areas where other residents were able to work from home were less likely to get COVID, and areas with high area deprivation and more single parent homes more likely to get COVID. And so what we wanted to do next is do a cluster analysis. So essentially what we did is we took all of these neighborhood characteristics that associated with developing COVID-19, and we clustered patients by like neighborhoods. We ended up with 4 clusters, so 1, 2, 3, and 4. And then you can see the leaves of this dendrogram represent positive tests or negative tests. So the negative tests are shown in pink and the positive tests in green. All right, so you can see that some of the neighborhoods, the tests were much more likely to be positive, 40 and 44%, clusters 1 and 4, and you can see that those are characterized by more minorities in the neighborhood, higher area deprivation index, more room crowding, less home ownership. These are the factors that increase the risk. So I think in addition to individual level risk factors, there are neighborhood level risk factors that increase the likelihood that a patient develops COVID-19, a lupus patient develops COVID-19. So now we wanted to look at whether or not individual level factors trumped neighborhood level factors. And what we found, interestingly, is that regardless of a patient's age or BMI, neighborhood cluster groups, so the kinds of neighborhoods they lived in, increased the risk of developing, independently increased the risk of developing COVID-19. So now we wanted to look at individual level factors that really came out in the analysis for predictors of hospitalization. So we found, given that patients had COVID-19, being of a minority background and having more comorbidities individually associated with the risk of hospitalization. So what are we learning from this? So in concordance with what we learned from the Global Rheumatology Alliance, we found that lupus patients with COVID-19 were highly likely to be hospitalized. We found no association between any specific immunosuppressant medication, although we think a larger cohort would be important. We also found that comorbidities, non-white race, higher BMI, and increased the risk of hospitalization. And the mortality rates at the time, so you have to remember that this was done early in the pandemic. So in New York City in general, the mortality rate was very high at the time. So lupus patient mortality rate was about 10% in our study. And so I wanted to show this. I wanted to show that the Hopkins group for public health has this actual COVID risk calculator where you can actually go in and put in your specific neighborhood and also your personal demographics and look at your COVID-19 mortality risk calculator. So actually, I calculated my own risk based on my demographics in the area where I live, and then I added the risk factor of lupus, and you can see that my risk is about the same per 100,000 people. But any of you can go in and look at this if you are interested in doing it. So a word on the vaccines, because I know that there are lots of different kinds, and we are going to talk about this extensively in our panel. But I want to point here first, because we're getting all these efficacy numbers, 95% efficacious, 70% efficacious. And so I wanted to sort of orient you guys, because when you look at the flu influenza vaccination, the effectiveness is about 44% on average, some years more, some years less. So I want to make the point that the vaccines are coming out are very, very effective. So the AstraZeneca is about 70%, the chickenpox vaccine varicella is 92%, and the Moderna and the Pfizer, 94 and 95%. So this is fantastic news. The other thing I want to do is point out some of the ways in which these vaccines are being made. So the first thing is, if this is a little diagram of SARS-CoV-2, the vaccines are allowing our immune systems to target these spike proteins, so these little black proteins on the outside, right? So that's important because those are what's important for allowing the virus to get into our cells. And so this is good information on why the vaccine produces a better immune response than the native response. So our bodies don't know what part is important, and so we may produce antibodies to any part of the virus. However, the vaccines are directing our immune systems to specifically target the part of the virus important for infection. Now, we have the Pfizer and Moderna vaccine, which are these mRNA vaccines. So this is the difference between immunogenicity and infectious. So these are immunogenic, they are not infectious. So you cannot get COVID-19 from these mRNA vaccines. The AstraZeneca and Johnson vaccines are these non-replicating viral vector vaccines. So they take a virus that's harmless to humans and they engineer them so that they allow the virus to express these spike proteins without being able to replicate. So they can't make you sick, but they do expose your immune system to the part of the virus that you need to make an immune response. So these are the other ones that are coming out, and the Johnson & Johnson just got a emergency use authorization. And then the Novavax, I think, is on the horizon. This is a protein peptide subunit vaccine. So I want to make a word about safety, because I know people are very, very worried about the safety of these vaccines. So it turns out that these mRNA vaccines are extremely safe and effective. And so I've made some notes here based on the recent CDC vaccine safety report data. And this was including, this was after the first month where 14 million people got vaccinated. And so what they found was in this VAERS, or the Vaccine Adverse Event Registry, there are about 7,000 reports of adverse events out of 14 million. So that's 0.05%. The most common serious side effect was allergic reactions, which were in the news, and that's about 4.5 per million people. So that's very, very rare. And in outpatients who got the vaccine, there were 35 reported post-vaccine deaths. These were not related to the vaccine, and they were consistent with general population reasons for death. So things like heart disease, cancer, stroke. Now, a lot of people were worried about pregnancy. So that data is to come. So about 15,000 pregnant women. So including this self-reported system, about 800,000 people who got the vaccine were given the option of being followed with surveys after a vaccination. And in this group, there are 15,000 pregnant women. And so we're going to get some good information on how these vaccines affect pregnant women in the coming weeks and months. And there was no mention of vaccine safety differences among autoimmune patients. However, you can go to this website and look up different populations of patients and see that there were no red flags for autoimmune patients. And this is a really great, really great news. Now, what side effects can you expect? So I hesitate to call this a side effect because this is sort of an effect, because when your immune system becomes active, as everyone with lupus knows, you might have some fatigue, or you might have some pain, myalgias, chills, low-grade fever. And that is actually true for this vaccine too. So it turns out for these mRNA vaccines, so these are the symptoms shown here, and you can see this is days on the x-axis post-vaccination and the percent of enrollers who are reporting. So this is first dose of Pfizer, second dose of Pfizer. So you can see that most people reported that they had injection site pain, and then a smaller percentage of people reported these fatigue, headaches, myalgia after the first shot, but that jumped up to almost 60% after the second shot. And this goes down precipitously with days post-vaccine. So you can see that people can expect to have these immune activation symptoms, but that overall these vaccines are incredibly safe and incredibly effective. So the ACR has weighed in on this, and this is my last data slide here. So they have published this guidance that you can see online on February 8th. And just to summarize this a little bit, the ACR's guidance is that decisions on vaccines should be made between doctors and patients first, but that patients should generally be vaccinated, as these are non-live attenuated vaccines. These are immunogenic, but they are not infectious. So you can't expect to get COVID-19 from these vaccines. Risk of flare is minimal and theoretical based on past vaccine experiences. Most medications can be continued. So your hydroxychloroquine, if you're taking less than 20 milligrams of prednisone, if you're on MMF, these medications can be continued through your vaccination. Some medications, however, need to be timed differently given the vaccine. So things like JAK inhibitors, your tofacitinib, your baricitinib, methotrexate should be held 1 week after each vaccine dose. And things like rituximab, if we can help it, should be given 4 weeks after the second vaccine dose. All right, and so I just want to acknowledge some of the people in our group, and we can move on after this. But we have our team of specialists who helped us collect that cohort: Jose Scheer, Rebecca Haberman, Rochelle Castillo. Our lupus team in general, number of people who helped with statistics, including one of my great mentors, Jasmine Divers, our recruitment team, regulatory, and then special gifts from the Bloomberg Philanthropies and NIAMS. And you can check out our paper here in the paper on the Neighborhood Deprivation Index is to come. Thank you very much.